Good afternoon to all of you. I do want to reiterate what Cheryl said in terms of the honor it is for us to have you in this virtual room to be able to conduct this exclusive panel interview on such an exciting topic that brings, in our opinion, important opportunities to help improve public health outcomes worldwide. We thought we would start off by maybe if you could tell us just a quick introduction, tell us your name, your affiliation, your role, or really anything that you want to share as an introductory point for us. So maybe we'd start with you, Professor Miller.
Yeah, thank you. My name is Michael Miller. I'm an international consultant in health informatics and eHealth strategy and systems. I've spent my entire career in information technology and the last 18 years in eHealth innovation and working on large and complex eHealth programs around the globe. Currently, I'm a member of the WHO Digital Health Technical Advisory Group roster of experts and a member of the WHO Europe Committee for Digitalisation and Health Information Systems. I'm also an assessor for the British Computer Society Federation of Informatics Professionals and an advisor to NHS England on their blueprint programme for eHealth projects.
Thank you. Professor Kalra?
Hello, my name is Dipak Kalra, and I'm the president of a not-for-profit organisation called the European Institute for Innovation Through Health Data that we founded several years ago to be a catalytic multi-stakeholder organisation to help everybody to get better value out of trustworthy use of health data. I have a roughly 30-year history of working in research and innovation in the areas of electronic health records and health information, mostly anchored at University College London and mostly working at a European level. I also develop international standards through ISO relating to health information and electronic health records, and occasionally get involved in projects and initiatives that are slightly broader, potentially globally.
Thank you. And Professor Barlow?
Thank you. Yes, I'm James Barlow. I'm a Professor of Technology and Innovation Management at Imperial College, London, based in the Business School. And I've been working on healthcare innovation issues for about 25 years now, focusing very much at the adoption and implementation end of the pipeline, rather than the sort of early stage development work. And I'm sure this will come out later, but I feel that it's the adoption end that's the problem rather than the R&D. I've worked in many countries and looking at innovation issues, worked with governments, with industry, all the range of stakeholders in healthcare. And I also run various executive programs for innovators in healthcare, particularly from across Europe.
Thank you. Thank you very much, and welcome again. So as we stated in the beginning, we want to squeeze every minute of today's discussion to have you tell us your perspectives and positions on these topics. So here's how we structured the conversation for today. So we have about 50 to 55 minutes discussing the policy trends and the challenges related to health innovation and access to innovation in healthcare. And then 50 to 55 minutes discussing the opportunities in advancing health innovation and access to innovation in healthcare. So in the first part of the forum, we're going to be focusing on your perspectives regarding what is the context in which access to healthcare innovations fit in the current global trends. What are or what should be the priorities, and what do you think are major challenges or barriers to increase access to healthcare innovation? So here our first question goes to Professor Miller. So Professor Miller, as a highly respected international consultant in eHealth and digital transformation, and as having had worked on these large and complex eHealth programs in many countries around the world, we wanted to start with your global perspective and ask you, in your opinion, where do we stand in terms of access to innovation in healthcare? And are there areas that are progressing more than others? And if yes, where, why, and how?
Thank you. So if I begin, healthcare systems globally are being challenged continually by demographic changes in population, increased patient demands and expectation, worldwide growth in chronic conditions such as diabetes, and shortages of clinical and allied staff. This combination of factors is challenging the fiscal sustainability of healthcare services around the world. There is a dire need to improve service, reduce unit costs, and improve patient outcomes, as well as support the move to a patient-centric integrated model of care and the move to a more preventative model of care. eHealth has a huge role to play in achieving these objectives, in my view. However, half a century since the seminal paper on eHealth patient records by Dr. Larry Weed, entitled Medical Records That Guide and Teach, published in the New England Journal of Medicine in March 1968, no nation has yet delivered a fully integrated patient summary care record. Innovation has been slow, in my opinion, though there have been a number of large eHealth programs around the globe and US dollar billions of expenditure, as examples, NHS England, Canada Infoway, USA, and Australia. There remains, unfortunately, a significant way to go. So let's look now at perhaps areas of progress. A move to patient-centric integrated care away from the traditional fortress structure of hospitals, primary healthcare, mental health care and social care, particularly in the UK, Australia, New Zealand, Asia, Singapore and latterly China, is one area of progress. Most recently, telemedicine, perhaps as a result of the COVID-19 pandemic, has grown, though it perhaps lacks the objective element, patient vital signs measurement in a virtual appointment with a clinician. So from my view, it is a political solution rather than a clinical one when we go into a virtual appointment. That said, there is significant progress in advanced clinical grade wearables, with the long-awaited holy grail of truly non-invasive blood glucose measurement hopefully just around the corner. Progress with 5G increasing the reliability of communication and increased bandwidth. Chronic disease management, including patient segmentation on the basis of risk. Lifestyle coaching, diet, exercise and mental well-being. Significant developments in the US with Apple, Amazon, Intel and Omada as examples. In South Korea with Samsung and in China with Huawei, and the use of telemedicine developed for their space program being used as a base for population-wide service via their system WeChat, now termed in the medical domain WeDoctor. There is additionally some evidence of more structured approach to the challenges of semantic interoperability. I think the biggest problem that eHealth suffers from currently, which currently looks focused around the European Commission and the WHO Europe. I'm actually engaged in some work around that. That stretches beyond ICD-11 or SNOMED CT, but looks to address the dictionary of medicine and devices, pathology, diagnostic imaging, and regulated clinical terminologies and ontologies. That is my brief introduction to my view on the current state. Thank you.
Thank you. Very, very informative. Thank you, Michael. So now let's move on to Dipak. So Professor Kalra,
Yes.
As a leader in research and development of eHealth, you mentioned you have over 30 years of experience here, and someone that, as we understand, is integrally involved in regional initiatives that drive innovation, such as the Horizon 2020 and EMI. In your opinion, where do we stand in terms of prioritizing development of major health innovations and finding sustainable health solutions in healthcare? And are there areas of the world that are progressing more than others? And if yes, where, why, and how?
Okay, that's a serious challenge. Let me do my best, but I will. My colleagues may have to jump in and rescue me a little bit on this. But can I just start with kind of the why before what we're trying to achieve? And I'd like to sort of, I mean, Michael has very nicely described some of the areas of digital innovation that are really at our fingertips now and allow us to do things better and smarter. But we need to remember that the underlying issue that should be driving innovation is a kind of squeeze that we have as a society in many parts of the world, you know, an aging demographic, which in itself is not the biggest issue. The biggest issue actually is multimorbidity. Our first chronic disease doesn't kill us anymore, thankfully. So we go on to get the second and the third and the fourth. And what we are going to be seeing is an increasing proportion of the population with 2, 3, or 4, or even more long-term conditions. And the problem is that managing long-term conditions adds substantial complexity to healthcare delivery. And most of our healthcare models are still very silo-based. That is, we don't even organize our healthcare, you know, within buildings. We organize it within specialties within buildings. And we have still a very poor evidence base and a very poor history of connecting. The other big issue really that we've got to address is that we are at a stage, probably in most parts of the world, where there is not likely to be a substantial increase in the available budget. That means we have to be able to handle increasing care volumes, very expensive high-tech innovations and treatments, and complexity within the same budget. And that also forces us, I think, to innovate. And a big player that is ignored in our innovation space is the patient. In other words, the person who could become an active player is still largely handled in a patronizing model in most health systems. So to me, what we need from digital innovation is improved care connectivity, which has two parts. It has a data part. We really need still to rescue that situation. Michael referred to the lack of interoperability. We still have challenges in sharing even basic patient data between organizations, but also joined up care pathways where the handshaking in a partnership model between different teams and specialties is well orchestrated and evidence-based, so people are part of a coordinated care plan that includes them all and includes the patient. And so patient self-care, telecare, not only in disease treatments, but actually prevention and health optimization. These are the areas that we really need innovation in. They are health system transformations because they are not going to be solved by throwing a technology piece into an unchanging ecosystem. And here I think James may pick up on themes like this because this feels like his expertise area, although I keep encountering it more and more in my own travels. One other area I would like to raise is the data ecosystem. A glue or a fuel that powers digital innovation is the ability for any digital component to be able to access, reason over a holistic patient record. And so we go back to that joined up data issue. And it's not only about point of care delivery that I'm now speaking, but the data ecosystem has to be better harnessing research and innovation, because research and innovation itself needs data and today has many barriers of access. Now, you've asked me to give a global perspective, and I wish I could tell you that I've really looked across the globe in a very holistic and detailed way, but I haven't. But what I can tell you is that where I have seen rather breathtaking scaled adoption, not pilots, but really scaled adoption, have been in countries that seem to have a lower legacy. That is, that they have less already invested. And maybe, if I could suggest, but without evidence, so please treat this as rather a personal opinion, less vested interests that safeguard the status quo or control it. So really the ability to be innovative and creative in redesigning holistically is something that I've seen. And the examples I actually have heard about that I've been struck by have been in the Middle East, where it seems to me that they have both the resources to invest to change, perhaps in some cases fewer legacy infrastructures, maybe also a very strong central mandate that allows them the ability to flex the muscles and introduce change in a potent way.
We have a quick question around more like the current events is, how do you think that the COVID pandemic has impacted progress towards prioritization of development of health innovations and towards ensuring access to innovation in healthcare?
Well, on one level, I could say that what it has woken up nearly every country to is the importance of having greater remote services for patients, because the ability for them to walk in the door of a clinic or a hospital has been impaired because of COVID-19. And where they've had telecare, telemedical facilities, those have been scaled up. Where there were portals, those have become enriched and are used much more. So you could say COVID-19 has helped to accelerate digital innovation and woken people up to the need for it. But I would have to say that I've seen a lot more. I'm going to use the phrase string and sealing wax solutions. It's an English expression, and basically it means solutions that are quickly put together, not necessarily robustly, and might not have long survival. And really, I'm now feeling a sense of almost, we're not quite there, but nearly post-COVID. We're not at post-COVID yet, but people are thinking we might be getting close to post-COVID relief. Let's catch up, let's recover, let's clear some waiting lists and so on. And that momentum that should have been stimulated to say we were poorly prepared, poorly digitally prepared to have the rug pulled under our feet for service delivery, we now need to be resilient. There is a lot of resilience rhetoric. What I'm not seeing much of is resilience action. So I'm a bit personally confused about whether I feel COVID-19 has been a valued catalyst, even though a hated disease, or whether COVID-19, we will look back and say, well, it caused a lot of flurry, but it didn't sustain the momentum for digitization that it could have done. Yeah. And I'm not sure yet. I feel myself a bit uncertain.
Yeah. Great. Thank you. Thank you for that insight. So now we want to turn to you, James, Professor Barlow. So as someone who centers her work on adoption and implementation and sustainability of innovation in healthcare systems, we wanted to ask you if you could please share with us some of these successful strategies or mechanisms that has led to an improved environment for fostering health innovation, and or some of these mechanisms to ensure access to innovation in healthcare, and what made it successful in your opinion?
Okay, thanks, Maria. Yes, I mean, I can pick up a lot of the points made, but I think when it comes to thinking about strategies for fostering innovation and improving access to innovation, I think it's important to distinguish between mechanisms which are designed to foster the early stages of the innovation process in healthcare, and mechanisms that are designed to foster later adoption, implementation, and diffusion. Of course, it's all connected, but I think one of the problems is that you need different approaches, different tools at different stages, because the challenges for innovators, policymakers, funders, adopters vary across those stages. And I think a big problem has been that the overwhelming emphasis from policy initiatives and funding initiatives and so on, until pretty recently, has been on the early stages. So there's lots and lots of funding for research and development, and very, very little for adoption and implementation and spread. And by the way, I'd make a distinction between adoption and implementation, because I think it's easy to make a decision to adopt an innovation and do a pilot project. It's very difficult often to implement it and embed it in mainstream care practice. Just to focus on adoption and implementation, which I think is where the bulk of attention is actually needed. I think the problem is this question of scaling up from pilot to mainstream implementation. And I mean, the barriers, I'm sure everybody on the call knows the barriers, that they're well known. They're to do with the quality of the evidence base for the potential benefits of the innovation, the difficulties of gathering evidence, difficulties associated with the organizational context, the complexity of health systems, the silos that Dipak mentioned, the complexity of innovations themselves. And I think we've heard just in the last two answers to the questions that, we're talking about digital health, remote care, data-driven initiatives are immensely complex as innovations. They're not just a widget or a new drug, for that matter. They're a bit of technology plus a lot of process and organizational change. So when you've got complex innovations being deployed in very complex contexts, health systems, inevitably it's very difficult. Just to turn to strategies and mechanisms briefly, I mean, UK is not perfect, but there has been a lot of effort going back to the early 2000s in the UK to try and pay more attention to adoption and implementation, and put in place a sort of support infrastructure to help innovators and adopters at different stages in the journey. So a lot of this is about connecting innovators with users of potential innovations. It's about sharing knowledge and lessons from pilot projects. It's about signaling local innovation needs, bridging boundaries between research, industry, healthcare provision, and so on. So, for example, we have the whole of England is covered by academic health science networks now, which are designed to try and achieve that sort of bridging across the boundaries. At an individual level, we have the National Health Service's Innovation Accelerator Fellowship Programme, which supports clinicians, entrepreneurs, academics to scale up innovations. There has been some effort to try and recognise that implementation of innovation costs money. So healthcare organisations have to invest time and resources to move from a pilot to mainstream implementation. So there's been some effort to try and put in place the right kind of funding support under certain circumstances to reimburse those costs. What else? There's an accelerated access scheme for medtech and certain drugs to try and identify desirable evidence-based innovations and speed the process of procurement. So I think, there's a lot going on around the adoption and implementation end, as well as all the funding for R&D and the basic science. Those kinds of initiative work, I think, when they really understand the complexity of health systems, they understand the complexity of the innovations themselves, and they're able to take a sufficiently long-term view, which acknowledges that adoption takes time, and it can take time for the impact of innovations to become apparent. So you need to nurture innovations and their implementation journey. So I mean, there's a whole host of ways of fostering adoption, but I'm just trying to give you a little bit of an insight into some of the things that are going on in the UK.
Fantastic. Thank you for that. And we did have a follow-up question for you, James, is that especially given your research and some of the teaching that we read about that focuses on innovation processes in healthcare systems. So in your opinion, and I think you touched on them just a little bit, but maybe if you could expand on what are the necessary elements that need to be considered in strategizing and implementing successful mechanisms that improve access to innovation in healthcare, and to ensure that the development of health innovation is encouraged and supported?
Okay, I mean, I think probably the most important thing for me is understanding who the key stakeholders are, whether they're healthcare providers, funders, patients, clinicians, industry, and so on, and really listening to their views about particular innovations, bringing them on board and engaging with them early in the development of strategies and policies. So I think that would be the number one priority for me. And if you're trying to design mechanisms to support access to innovation, you've got to talk to the right stakeholders and get them to buy into the mechanism or policy. So that would be one. I think simplifying and streamlining the regulatory processes is essential. I think you just have to make sure that everybody understands what those regulatory processes are. Make sure that there's no unnecessary duplication. Make the journey from R&D to from bench to bedside, as I say, as straightforward and simple as possible. Certainly in the UK, there's also been a problem around the sheer complexity of the landscape of mechanisms for supporting innovation. And 10 years ago, there were many overlapping bodies, many different sort of routes, pathways from initial development and initial funding support through to procurement and adoption. They've now been simplified to some extent. So helping innovators navigate the system, I think, is very important. Procurement, I think more can be done in terms of procurement, creating a sort of commercial dialogue earlier in the innovation process between purchasers and innovation developers, to make sure that the right kinds of innovation are actually coming through the pipeline. And perhaps create more flexible arrangements for paying for innovations and so perhaps giving innovators early access to the market in return for some agreed outcomes. I'm sure we'll come back to public-private partnerships later on. Designing the right incentives to share risk and reward. And Dipak mentioned patients as well. I mean, I think absolutely at the heart of all this is patients and informal carers as well, and giving patients a more central role in determining what innovations are important for them, making use of real-world experiences to help shape priorities, and using that real-world data to, to feed back into the research and development process. Absolutely crucial, becoming much more easy now that we have vast amounts of data and better data analytic tools. And finally, nurturing patient-driven innovation or user-driven innovation. I think something like 25% of medical device innovations originate from users themselves, whether it's patients or clinicians, but huge amount of patient-driven innovation. Do we know about it? No, it's out there, but it's not really, we haven't harnessed that knowledge, I think. So just a few thoughts there on things we ought to be doing, I think.
So now we want to change the perspective a little bit and discuss some of the challenges. So now that we have a better understanding from each of you in terms of the current context and the needs for successful strategies to prioritize and support the development and access to innovation in healthcare, we're curious to learn a little bit about the challenges. So we have two questions that we want to pose: first, challenges, then solutions. But let's focus on the first question. So maybe starting with Professor Miller, back to you from your global perspective. What are the major barriers or challenges to truly improving access to innovation in healthcare? And furthermore, what are major barriers to creating national policy environment that encourages development and adoption of health innovation?
So as we move forward towards healthcare without borders, internationally agreed standards, in my view, need to be defined and adopted by those be those comprehensive clinical vocabularies or ontologies, as perhaps in a more simple way was recognised in the flight industry in the 1940s. Every pilot would speak English. I mean, it didn't really matter whether it was English or not, but we adopted a common language, which we still don't really do in healthcare. And an international approval process agreed for example, AI, wearables and other devices. Perhaps, I don't know, the British Standards Institute, which operates in 120 countries, might play a role in that domain. Another area, I think, and I've already mentioned it, and it's been mentioned a couple of times, is semantic interoperability. And EHR vendors, electronic health record vendors, playing a more positive role. You know, there are some major ones who actually say they're not going to be participating in interoperability, and it's proved to be a great stumbling block in the access of available data to manage patients, but also for research purposes. I think, as already been said, patients playing a large role in the management of their conditions, as Professor David Cutler, Professor of Applied Economics at Harvard University, said in the MIT Technology Review. Perhaps the most underused person in healthcare is the patient. So we need to kind of encourage them with diet, exercise and mental well-being. And I'm seeing devices now that claim, at least it's early days, but to be able to measure in a quantitative mechanism patients' mental well-being. There's some interesting work going on at King's under Dr. Matcham. In terms of barriers, perhaps vested interest is a block to innovation, and with demographic changes in population and the growth in chronic disease, the fiscal sustainability of provision is in question. We need to encompass the use of eHealth and telemedicine to automate the routine and permit available clinical resources, to be able to address the more complex cases. So I think that's the main role that healthcare, and also by moving towards a more preventative-based healthcare. So if we can monitor our young very early with blood glucose, for example, we can perhaps encourage them to adopt a healthy lifestyle right from the beginning. And so we operate a more preventative healthcare system rather than one that deals with the treatment when they're 50 or 60 years old. And one additional and much neglected area is perhaps effective use of genomic and genomic data. I think I'm regretful of the lack of progress we've made in that domain to enhance our healthcare system and support our clinical professionals. You know, I dream of the day of 3D printing of medications designed around the patient's genomic sequence. It's an ambition that I have. I think they're the main points that I would like to make on that in answer to that question. I think there's also what is needed to overcome these challenges that you might come on to in a minute. Thanks.
Thank you. Thank you very much. The same question to you, Dipak, and then later to James. I'll just repeat the question. We're looking at what are some major barriers or challenges to truly improving access to innovation, and what are major barriers to creating a national policy environment that encourages the development and adoption of health innovation? So maybe Dipak?
There's inevitably going to be a bit of an overlap between what the challenges are and what we've been discussing previously in this discussion, because to some extent they're interwoven. So I'm going to pick a couple that I would like to really focus on. The first one, I think, is reimbursement. I don't feel that we are, and I guess really I'm speaking on with the primary vision of what's occurring in Europe. So let's accept that limitation geographically for me. But when I look across European countries, I do not see much sign of innovative, smart reimbursement models that would actually use the financial lever that it can be for change. Yes, okay, the classical term reimbursement is used for digital health to mean, you know, can you reimburse the solution? Can you pay for the app? Can you pay for the tech? But usually dropping tech, and I think we've echoed this already, dropping tech into an unchanged care pathway, an unchanged organizational model basically does very little. In other words, you don't really benefit from it if you don't behave differently. And so what you actually need is financial incentives for changing care pathways. That might mean changing which organization has the bigger piece of the action when it comes to treating a particular health issue. And that could mean that you've got winners and losers in terms of work, potentially winners and losers in terms of income in that kind of game. And so when you need to change care pathways, you've got to look at how does smart reimbursement enable people to act, even if they might lose a bit as well as win a bit. And then the other thing that I think actually picked up a little bit on something that James said, but it's something I've felt very strongly about for a long time, is that even if your eventual end game is a different care pathway, digitally enabled, that will be lower cost to deliver, it costs more to introduce the change. Because for a while, you've got people with a heavy cognitive load. For a while, you've got to run an old system and a new system in parallel. It takes a time to decommission the old way for every single patient that might be impacted. So there's reimbursement that's needed right across the change, the transformation ecosystem. And then the second thing I really feel that we are still weak on is healthcare business transformation. I think the skills are not really out there at the density that they're needed for the extent of change that we need. And again, I think we need incentivization that is not the digital, but really about the holistic changes in care. For example, I've watched the struggle of the concept of value-based care, which still lives in microcosms, when the whole mission of value-based care should be something that excites all of us and which we jump into with both feet, but it's happening very slowly. So to me, those are the biggest ones. There are others around the data ecosystem, around digital skills of the workforce, around having an innovation-friendly market where the process of getting approved and generating your evidence of effectiveness is not handled in a good way. In my experience, I engage with a number of people doing digital innovations and also pharma, creating innovative therapies. And it seems to me that the burden is always on the innovator to prove why their innovation should be used and why it will benefit patients and how it's affordable. But a lot of the data that their evidence would depend on is actually held by the health systems. It isn't always available to the innovator. And I don't feel the adopting community, the health systems, even the payers, are meeting the innovator halfway around that evidence generation obligation. It's just dumped on them. It's almost as if to say, and this is a very prerogative phrase, so it's very personal. Nobody's said this to me. You can't quote anyone else. It's just me saying, if I was on the receiving end, I'd be saying, we don't really want your innovation. If you really insist, you've got to really prove it's worth our while taking an interest, but we're not that excited to have you on board. All the efforts on your side to win us over. Now, I will just say a couple more things, if I may, because you've asked about kind of policy. And to me, the policy barriers that are impacting on digital innovation adoption are the ones that I particularly see are the fact, as I've said before, you've got to initially spend more to save. And that isn't politically something that people like admitting to their electorate, that temporarily I've got to invest more in this thing, even though we're all trying to cut budgets and save money. And that goes hand in hand with the lack of quick wins. Politicians in general like things that will deliver an ROI, a return on investment, with roughly 50% of their electoral cycle. They need a year or so to embed in their ministry or whatever it is. They then need to do something radical. Within a couple of years, it's got to deliver because they need the final year to put it into electioneering. I know that again sounds a bit glib, and I apologize to politicians that are nice. But in general, what I see is it's quite tough to get things that need longer to embed and deliver value to be politically adopted. And I find it very contrasting when I speak to people in ministerial environments, and then I speak to health insurers, the not-for-profit health insurers in some European countries that have been going for decades and expect to continue to go for decades. Sometimes they blow me away. And I remember speaking to a French health insurer saying to me, Dipak, you're referring to, investments in prevention and other things that might take, 20 or 30 or 40 years to deliver a return. And, getting school children not to smoke probably will not deliver a benefit in terms of health costs for about 30 or 40 years. They say, that's not a problem to us. We insure families. We're going to insure the next generation. It doesn't worry us that we may invest at times in things that deliver 30-year return. But I've not heard politicians say that to me yet. So I'm perhaps giving you a jaundiced view, but I'm just giving you a view of what I've heard, people I've encountered. It's not evidence-based, it's anecdote-based. But those are the barriers I see to putting in place policies that will really transform health systems in a digital way.
Thank you very much. Very insightful. So we've talked a lot about these challenges, but Professor Barlow, I don't know if there's anything else that you want to add in terms of these major barriers or challenges to improving access?
I think one of the issues that has to be dealt with in the future is the sheer lack of integration between the different component parts of health systems. And we've heard integrated care mentioned a couple of times. We simply need to rationalize and integrate between the different component parts of care systems much better than we do. We've got all these organizational silos and silos within silos that were mentioned. It's happening in different ways and in different places. It's a very slow, long-term project given the vested interests. But I do think more integration will make a difference when it comes to taking on board innovations and ensuring that the costs and benefits fall more or less within the same sort of financial pocket, I think. Dipak, I think, mentioned, legacy costs, invested interests, and I think there's a huge path dependency problem in healthcare. So we've got an organisational, technical and built infrastructure in the UK that goes back 60, 70, 80 years, and it's very difficult to change. However much we know we need to do things, rationalise, centralise, close hospitals, open specialist centres, put in place telemedicine. It's very, very difficult to do when you can't just tear up the system and start again. So, and I heard again, I think it was Dipak earlier, talk about countries where there's a more rudimentary, less established health system. You can do more innovation there, I think, than you can in somewhere like the UK or other advanced health systems. I don't have an answer to that, I would say. I think the last couple of things I just wanted to mention were the weird economics of healthcare innovation. And I think there are two things here. There's the cost and benefits question and the fact they don't fall in the same pocket. So you get all these sort of reimbursement issues that need to be dealt with. But there's also, I think, the fact that technological innovation often drives up cost to purchasers, insurers, policy, governments. So the better we are at healthcare technology, the more we bring in, the more we can do, the more people we can treat. The more we identify problems that then need to be treated, and possibly in the long run that may have an impact in terms of taking some demand out of the system and dealing with prevention and so on. But innovation costs money. I mean, it costs money to implement it, and it often drives up cost as well. So I think there are some questions there around how you identify which innovations are truly value adding, and value adding for whom. And that can be very difficult when you've got innovations which may be complex and you can't do a neat randomized control trial on them. Gathering evidence for the benefits is very difficult. So all these issues, these discussions around value-based healthcare, value for money, where the costs lie, are immensely difficult, and we need to deal with those as well. I think if we're going to have a more a smoother path to adoption for many innovations.
So thank you for that. Maybe keeping with you, James, and if you can expand a little bit in terms of what is needed to overcome these challenges. So looking at this from the solution perspective, you talked about all these challenges in terms of cost, integration, political will. So so what is needed to overcome some of these challenges, and how can different stakeholders, including the private healthcare industry, help address some of these challenges?
Well, I think reorganizing health systems is, we know where we need to be, I think. We know we need a more patient-centric, preventative, integrated care model. And I think we know what needs to be done to get there. I think I mentioned earlier on, it's about engaging with stakeholders, in the system, and aligning interests, really. I mean, finding ways we can ensure that there are some win-win solutions rather than win-lose ones. But as I said, it's difficult because you've got a sort of legacy, a legacy health system which you can't just tear up and redesign from scratch. I think we could do more around the reimbursement and payment and risk and reward models. I mean, as I said earlier on, in the UK there are certain innovations where purchasers get reimbursed for the extra costs of implementation. So there are things you can do around that. I think we could probably be better at gathering evidence from trials and pilot projects and using new forms of data to combined with modelling to look at what the potential impact of innovations are when you scale them up and roll them out. Pilot projects don't necessarily give you the right kind of evidence to tell you what it's going to be like if you scale it up. So we can be harnessing data and data analytic tools much more effectively. So I think, there's lots of things to be done, but the really big questions are around the health system itself, I think, and how it's organised, and moving health systems from a sort of 19th century model to a 21st century model, which is patient-centric and integrated and preventative.
Thank you very much for that. Deepak, same question to you in terms of what would be needed to overcome some of the challenges that you discussed, and how can different stakeholders help address some of these challenges?
Okay, well, I think that probably I could just say a ditto to James and cover a lot of the things, but there is a stakeholder I really like to shine a spotlight on, and that is the patient or the citizen. I think that we know that probably the biggest health system transformation that is needed out of all of them is shifting the balance of care and autonomy and tooling and education to digital health literacy and data literacy into the hands of patients and citizens, so they really are strong players. We need that for financial reasons, because we can't afford to keep giving care to them and them just sitting down and waiting for care to arrive, but also because they have huge potential to personalize and customize their care, because they are the person who's experiencing it. And the tools and technologies are there. So I do think that's important. But actually the biggest thing is that most of the actors in the health system who are near the bottom up hierarchies, the ones impacted by most of the issues we're describing, are themselves kind of salaried, employed. They are inside organizations and not taken seriously. I think the citizen as a change agent, as a catalyst for waking up the top down, is an underestimated resource and energy. So I would love to see us empowering our patients and letting them help to drive the changes that we need.
Thank you. Michael, if you have any further thoughts in terms of what would be needed to overcome some of these challenges and how different stakeholders help address these.
Yeah, I guess there's quite a bit of agreement amongst the three speakers today. I mean, my thoughts on this are as follows: as previously stated, standards across the approval and healthcare domain, to me, are very long overdue and fundamental. We have to be able to integrate our data and preserve meaning in that integration process. And that will give us a great leap forward on the integrated care model, as an example. I also think, talking about UK research, and maybe the outcome from that has been disappointing. perhaps, and we need to revisit some of that. But international collaboration on research, addressing sort of the needs and outcomes with a view to a sort of international market, I think is very important, and that includes developing economies as well. As I've worked around the world, and I found the same political issues that Dipak mentioned everywhere I've been. It's quite disappointing, really, in spite of different ethnicities and religions and political systems in different countries, they seem to operate in a pretty similar way. So, there's huge need in Southeast Asia, for example, Pakistan, Bangladesh, Indonesia, the Philippines, and Africa. And I would really like to see sort of joint collaboration between, the US, Europe, China, for example, so that we can really help these people and assist them and ourselves in that case. As kind of Marshall Plan, if you like, almost. And I think there would be huge benefit and also huge markets for, our companies like the Apples and the Intels and the Amazons. So, and also in the sort of uncertain political world, when you help people with their healthcare, you win friends. And I think that's very, very important, personally. I think we also need to address, as my previous comment indicates, the address of affordability of such technologies worldwide. I know when I've worked in countries, for example, in the Pacific Ocean, and they've wanted eHealth systems, and I've contacted the big corporates and said, look, they've got $20 million from the Asian Development Bank. Would you be prepared to implement eHealth records for them? Basically, the response I got, in somewhat paraphrased, is put another zero on it and we might turn up. Well, then what do? Where do they go? There's very little in Europe, for example, in terms of electronic health record vendors, and it becomes extremely complex. And I think where we might look for sort of friends in certain geographical areas, we can do a lot in that domain. I think important also is minimising hype. I'm sick of the number of times I hear about AI and what it's done, when actually it has very little impact at all, unfortunately. And I'm not saying there isn't a huge need for it.
Starting with you, Dipak, and as someone who champions learning from and improving how we use health data, something that your institute, you mentioned, does, is how do you see the issue of innovation evolving in the next 15 years? And what do you think are the opportunities, or what would you hope for in a future world in terms of promoting health innovation and ensuring access to innovation?
Well, I think that the one thing that we could sort of guarantee about digital transformation of healthcare is if we left it alone for 15 years, by some sort of natural evolution, it's going to happen anyway. There will be a gradual normalization of using digital technologies. But that will be a very slow evolution. And one of the things that I think will help accelerate is the challenge of capacity, of how to increase health system capacity and coping resilience in the face of the challenges that we've discussed previously, which is increasing demand, increasing complexity, but not a corresponding increasing budget. I think one of the challenges, though, for innovators is access to data. We've got two different problems that come at different life cycle points. One of those is at the point of developing the innovation. A lot of people that I speak to, whether they're small companies or bigger ones, whether they're in the med tech sector or the big tech sector or the pharma sector, they all have a universal problem, which is that they badly need large volumes of relatively fine-grained, close to real-time patient data. Close to real time, meaning that if you've got innovative sensors, it's no good having data from a year ago because they were working on different algorithms then and using different devices then. They need things that are reasonably up to date. And in order to stimulate innovation, we have to find pathways of making that data more readily available in data protection compliant ways. So I'm not wishing to say that we override anything that protects data subjects, but in ways that safeguard them. We need better channels and methods for them to get access to the data. And then the second part of the story is every digital innovation is operating on a piece of a patient or a piece of a disease or a piece of a care pathway. But its reasonings, its algorithms, its advice, its guidance is only going to be realistic and accurate and safe if it has access to the holistic patient record. In other words, determining whether a patient should take an extra dose of a particular medicine because in the app they have indicated a severity of a symptom that's higher than normal, and the app would normally say, yeah, you should take 2 tablets instead of 1 at the next point. That does depend on what else the patient is taking, what other medicines the patient is taking. And if the medication list has changed and the app doesn't know that, it may make an unsafe recommendation. So the holistic data ecosystem for the developer and the deployer and user are a critical success factor in my view. And I see a real acceleration of interest in this. Right now, the European Commission is investing heavily in something called a European health data space that is going to act as a forerunner, but actually there are other initiatives already existing at national and cross-national levels. I think the data ecosystem is going to be a very powerful accelerator of digital innovation.
Thank you. This next question also goes to you, but also to Michael, to Professor Miller. But I noted also that, James, you had commented on this specific question that we want to ask, which is health innovations encompass a broad range of solutions. So we have telehealth, robotic surgery, innovative diagnostics, wearables, etc. So from your perspectives, which of all of these technologies are ripe to making a real difference? And furthermore, what do you foresee will be the necessary conditions for any of these innovations to truly make a difference in the near future? So maybe starting with Professor Miller.
Yes, I suppose pre-pandemic, the WHO suggested that the single biggest cost of healthcare provision worldwide was chronic disease. And we're seeing huge increases in the growth in chronic disease and looking at diabetes, largely type 2. The International Diabetes Federation suggests that there'll be an increase in the number of diabetics worldwide by 51% by 2045. So it's a huge problem. You know, China's expected to have 140 million. Middle East is going to see a 96% increase. Africa, 143% increase. You know, the US in 2015 spent, I think, 585 billion on diabetes alone. This was without others. So for me, one of the areas is chronic disease. And I think one of the best ways that we can move forward is in the telemedicine domain, with an integrated ecosystem that supports a patient in an integrated care system covering multiple conditions, comorbidity. And you know, with the patient data passively generated. And the reason I mention that is if a patient has comorbidity and you ask them to take their blood glucose 4 times a day, you ask them to measure their blood pressure twice a day, to take their temperature or whatever it might be, a whole range of measurements. And they will do it for a while, but then they soon become fed up with it and it tends to drop off. So if we could wear something, so we have minimal patient intervention, I think, as taking Dipak's point, the current data would be available, and then we could use data analytics, I prefer to use rather than AI, to sort of look at that data and to see if there's a possible intervention is required, and then generate an intelligent-based alert, minimising false positives and false negatives, so that we really have an effective system. And then support the patient, which probably the biggest issue is lifestyle changes, diet, exercise and mental well-being. I think another area is the wearable development, basic requirement and usability of data generation for the affordability that's needed to address the data problems. I think semantic interoperability, I keep coming back to this because it's fundamental to have a holistic patient record, needs to be finally addressed. And it's been a half a century, and it really is time that was dealt with. And it's not just for the patient's care, but also for the secondary uses like the development of data analytics and AI, for example.
Mm-hmm.
And I think my fourth one is perhaps the supply of high quality, affordable healthcare that addresses global wealth and political influence matters. I've worked around the world where one might be exposed to pressure by saying, please make sure this contract doesn't go to this country. I won't go into detail. The issue for me is not who the contract may go to, but is it affordable for the customer, and will the patients likely benefit from the implementation of those systems? So I think the politics is very important, and the way our political systems undertake links with other countries. I think we can win many friends around the world, huge markets, but we need to have perhaps a more greater empathy with those developing nations. That's my view. Thank you.
Thank you very much. Dipak, I don't know if you have anything to add or to comment around the same question.
Well, I mean, it's actually a very exciting list. I typed it up and I just keep looking at it and imagining. I mean, you've got a nice list there: telehealth, robotics broader, not just actually, I mean, robotic surgery, yes, but I've actually seen, for example, little tiny robots that will do rehabilitative exercises that kids will mimic. Kids will not watch a video of somebody showing them how to do exercises, but they will mimic a little tiny robot. Absolutely, they will. So in a way, almost I would invert your question. Which of this lovely array of innovative areas you described is not able to make a difference? I think they're all capable. The problem is where and when do they fit? So in other words, it depends on the purpose to which you apply it. So the ripeness that is needed is not really in any of those technologies, but in the receiving end, and saying, are we ripe and where do we best receive it? But I will also say there is a message to the inventors too. So often I encounter solutions looking for problems. And I think that I'm not sure whether Michael's view on AI is colored by this, but there is a risk that AI algorithms are developed by computer scientists because they see data they could get hold of, algorithms they think are exciting to develop, where they can get a good degree of accuracy quickly, but without actually asking healthcare whether it has a need at that point. Is that an area where humans are struggling to make evidence-based decisions, or where the complexity of patient diversity is such that AI level of input is really valuable to help the right patient have the right decision being made? So what I would really like to see is not solutions looking for problems. I would like healthcare maturity to help indicate where innovations could plug in and be welcoming when they arrive.
Thank you very much. I don't know, James, if you want to comment on this question.
Yes, I mean, I think on the access question, what I wanted to say really was around the huge social, economic geographical disparities in health access and health outcomes. And, we know that every country is bedeviled with these huge differences in access to health services and the implications of that for patients and for citizens. I mean, I think technology can help. Telehealth can help, certainly. And it can help address some of the causes of these disparities, but only some of them. And I think dealing with health access and health outcome disparities is something that is much deeper than putting in place some technologies. It's about tackling deep-rooted structural problems around income distribution and quality of housing, education, and so on. So, no amount of home-based telemedicine or telehealth will compensate for poor quality housing. So I think, when we talk about access, it's not just about access to innovation, technological innovations. It's about thinking about access to healthcare more generally, I think, and tackling those disparities. The other thing I wanted to say is, sort of mentioned earlier, was just around the type of innovations that are typically produced, and not only are they solutions in relation looking for problems, but they are hugely expensive solutions, which are just not affordable in most or many healthcare systems, particularly in developing parts of the world. So, thinking very carefully about the costs of those innovations and the whole life costs, not just the initial purchase cost, I think is a very important part of the access question. There's been lots of discussion in the last 20 years around disruptive innovation and frugal innovation and cheaper, simpler, but good enough solutions. So I think we could be doing a lot more to encourage those kinds of innovation in healthcare, and not just the high-end, advanced technological solutions.
Okay, great. Actually, James, we have a couple of questions for you, and these come because the body of evidence that we looked at, that you've developed and you have published is quite impressive. And I was wondering if you can help us with this wider viewpoint to address the following two questions. The first one is related to access that you were talking about. What would you consider are the determining factors or the actions that are needed from governments or other stakeholders to ensure access to innovation in healthcare? And specifically, what are these set of ideal policies that would enable sustainable and equitable access?
Yeah, I've sort of struggled with this one a bit when you sent it to me, and I had a look at it this morning. Partly around this access question, and I'm not sure I could present an ideal set of policies, because I think the policies are going to vary depending on what kind of country you come from and what type of health system and what it is you're trying to achieve. I think as we've sort of touched on a lot of the things anyway. One question for me would be just encouraging the right kind of innovation. So innovations that are truly tackling challenges that need to be tackled, and not just sort of nice, interesting scientific or engineering challenges. And finding ways of bringing together the needs side, i.e. healthcare providers, clinicians, patients, and developers of innovations and researchers, finding ways of just tying those two together in a way that allows you to sort of pull innovations that are needed rather than push them from the science that's being done. I talked earlier about the sort of support infrastructure and payment and reimbursement models, dealing with the sort of risk and reward and so on. I mean, I don't think we need to rehearse that again, but if you want to ensure access to affordable innovations, you've got to have the right financial mechanisms in place. I think the right kinds of incentives to encourage innovators and adopters to get the pipeline flowing. And I've talked about integrated care as well. I think more models where everybody is talking the same language. The primary, secondary, and social care side is better integrated, will help improve access to innovations. And I'm talking here about developed countries, really. Obviously, there's a whole set of issues around developing countries and making sure that technologies are appropriate, affordable. There's the right infrastructure for adopting them in those countries. I mean, all that is crucially important as well, I think, to ensure there's access to health innovations spread as widely as possible.
So the second question looks into the broader ecosystem that needs to be improved to enable development of innovation, and goes into how can these innovations be considered a priority. But I think I want to focus on the second part of the question, which is what kind of partnerships or mechanisms would be needed to encourage and incentivize development of health innovation?
Yes, I mean, I think here we're really talking about kind of the sort of partnerships which involve sort of innovative public-private partnership funding models, and so we've seen examples of that in drug development, in situations where there's been market failure, or for neglected diseases and so on. So there is some experience of product development partnerships where there's mechanisms to share risk, share reward, develop some kind of agreed set of outcomes, and mechanisms for remunerating on the basis of meeting those outcomes. So I think we could probably be doing a lot more around those kinds of partnership models. And as I say, we know that there are examples which we can build upon. I mean, I mentioned frugal innovation just now, so cheaper, simpler innovations. There's quite a lot of that around. Many examples in developing countries of versions of advanced technologies which have been adapted or developed in a more locally appropriate manner. So I think encouraging that kind of innovation, harnessing the knowledge of what's out there, understanding what works and in what context, and why it works, I think is an important priority. There's a growing literature on frugal innovation in healthcare, but it's still pretty small. So I think the interesting thing about that is that it also holds lessons for developed health systems as well. So there are examples of simple versions of, for example, diagnostics and scanning technologies developed in less advanced health systems, which have now found their way back to advanced health systems and are now being used by parts of those health systems which previously couldn't afford them. So it's a two-way flow of innovation. So really, just if we're talking about access, we have to be looking at partnerships between public and private sector. We have to be looking at harnessing knowledge of what's going on out there in interesting innovations in developing countries, and possibly making better use of that in our own advanced health systems.
Thank you very much for that answer. We want to move on to Professor Michael Miller. Professor, you have a long trajectory of advising many governments and even the WHO in the area of e-health innovation and programs. So we wanted your view on this specific question that goes in that says as follows. Health innovations will likely continue to emerge exponentially, and although they are expected to contribute to improvements in health outcomes, they may also negatively impact healthcare budgets. This is something that has been discussed in this forum as well. So in this sense, what do you think are the necessary elements or policies that will enable a broad adoption of health innovations, incentivize innovators, and ensure financial sustainability of budgets?
Thank you. Okay, so my response to that is this, I think, and the points that have already been made by other speakers, but change often leads to an increase in expenditure during the change process, while keeping existing structures in place while developing the new. And also, I think, ensuring the harvesting of benefits. I think it's important that we incentivize the delivery of the benefits in the use of these technologies. That's imperative. But I take on board Dipak's point that sometimes the benefits are not seen for maybe 10 or 20 years or even longer. But nevertheless, because of their long-term benefit, we still need to invest in those. And the problem, I've mentioned it before, I think, is the short duration of the existence of our politicians in their representative lives. And so what tends to happen is important long-term issues get kicked down the road and because they're not of any immediate benefit. I think policy standardization and ensuring that development in this domain is clinically led rather than technology led. And I come to this on the basis that I am not a clinician, but I am a technologist. And I've seen too many times the concept of technologists thinking they have the answers to every problem. And actually, we need to ensure that we listen to what the clinicians are telling us and where they most effectively we can help them, not tell them what's good for them. I think using technology to assist clinical process that one, move us to a more preventative model of healthcare. That's really important. Reduce unit cost. Encourage patients to be more proactive in their lifestyle and healthcare management. Assisting developing nations avoid the legacy issues of the West in e-health systems. And we can really assist that. So one of the things I'm pushing at the WHO at the moment, I'm speaking personally, is to try and have a standard vocabulary, because many of those developing nations do not have the necessary people to assist in that development. And if they can come to a body like the WHO, for example, and not just have ICD-XX, but also a whole range of clinical vocabularies and ontologies, then I think that they will really benefit, and they will minimise the semantic interoperability that haunts us in the West so much. And I think finally, my point would be that one of the big imperatives is the delivery of affordable healthcare to all. We've already said that many healthcare systems around the world are challenged, and that includes the US with its cost of healthcare approaching 20% of GDP. Doesn't matter if they go to Australia, where the predictions are dire by the turn of the century in terms of affordability. It's everywhere you go. So I think what we need to do is address that, because I'm not sure what happens to populations politically when healthcare is unaffordable. And it's not something that I hope I ever see. I think that's all I have to say on that issue. Thank you.
So we have two final questions that we'd love to cover with the time that we have left. So maybe the first question, starting with Dipak, given your experience, with the Health Data Institute, and as president of that institute, which is as we understand it, a multi-stakeholder institute. Can you give us your opinion regarding what is or what should be the role of industry in advancing access to innovation in healthcare? And furthermore, what is or what should be the role of industry in advancing to creating an environment that encourages and incentivizes development of health innovation?
Yes, you're quite right in noting that my institute does work across stakeholders, and although at times that means multi-stakeholder, at times it's multi-within stakeholder. And what I'd like to emphasize is pre-competitive collaboration here. We've discussed all the way through this event the challenges of taking innovations and getting them embedded into a complicated environment, and how the complicated environment struggles with how it can best embrace. And I think that whilst each individual company in an industry subsector will need to compete on the products it creates, there are quite a lot of ecosystem elements that they all need together. They all benefit from them. And what I have seen is that in the right settings, they will collaborate pre-competitively on enabling those success conditions, and then they compete on how they exploit it. So, for example, a topic that has come up several times in our discussions today has been access to health data. So if industry collaborates around the infrastructures and the methods and the availabilities of health data, routinely collected health data from healthcare, but even also their own randomized controlled trial data to be pooled and made available as a shareable resource, they can all compete on how they exploit it, but they can collaborate and get maximum win if they pre-competitively join forces on those things. There are other topics too, which are much more to do with facilitating change, care pathway innovation, value-based models, many topics where they all gain, but probably each company, however big its size, somewhat lacks the critical mass to change the game. But when they join forces and collaborate pre-competitively, firstly, they present a unified force. They do have critical mass. But secondly, they really are influential. I've watched people in public sector organizations feeling much more strongly motivated when several companies come together and say, we all want to see this change. We all want to contribute collectively in this area. It is a phenomenally powerful mood changer in conversations. So pre-competitive collaboration in areas that facilitate the ecosystem. That's really the punchline I would push.
Fantastic, great, thank you. James or Michael, any thoughts on that same question in terms of the role of industry in advancing access or in creating an environment that encourages and incentivizes a development of health innovation?
I completely agree about the need for pre-competitive collaboration. I think that's extremely important, and working within a sort of an ecosystem, I think, is clearly beneficial. I think. I would just add that I think there are some issues to deal with around pricing models, around models that provide sufficient incentive to develop the right kinds of innovation. I think there's a need for a much better understanding of value as opposed to cost in healthcare innovation. Where is this particular solution, this innovative solution, actually making a difference, adding value? How does it change the care pathway? Who gains? Who loses? So I think industry really needs to. I think industry needs to develop a much better understanding of value, actually. going forwards. I think industry can be doing more around dealing with issues about intellectual property and ownership of IP. There are huge differences between drug development and medical devices and digital apps, yeah, but certainly when it comes to digital health innovations, I think we're in the infancy when it comes to IP questions. And I mentioned public-private partnerships and product development partnerships previously. There is evidence that they can lead to innovation, I think, but they need to be. You need to be able to manage the relationships between funders and industry and purchasers of innovations to make those PDPs work, I think. So it's not an easy task.
On that same question, Michael?
Yes, but I'm fearing that I'm becoming slightly repetitive in my answers, so forgive me for that. But I think, one of the important areas is to initially address the most numerous and costly conditions with the most suitable technology to improve outcomes and reduce unit costs. I think that's where the private sector can achieve a lot. One reference on that might be the efficiency of leading industrial nations' healthcare systems. And we might look for that, for example, in the USA-based research organisation, the Commonwealth Fund. And their sort of reports are entitled Mirror, Mirror on the Wall. I've referred particularly to the 2014 and 2021 reports, which show the comparison of 11 leading industrial nations from a point of unit cost per person and also on clinical outcomes. So I think there's a lot there that the private sector, as it were, could learn from. I think also important is to, as I keep saying, agree suitable standards. And I attended a meeting recently with a number of the big players, Amazon, Intel, Apple, Huawei, and others. And they're all looking for, basically one set of consistent standards that they have to meet with their product, not just the FDA or the CE or whatever the Chinese equivalent is, but basically could we have one globe so they really can sort of make their processes as efficient as possible and gain global acceptance. So I think that to ensure the optimization of investment for them, which facilitates accelerated clinical development, is important. Which for them, I think, leads to increased market size because their product then can go truly global. And the commercial benefits while supporting sustainability of universal healthcare. So I think that's how, personally, I think that's how the big players in the private sector can improve their position. It's on delivery and global acceptance of the product at an affordable price. That's really how I see it moving forward. And I hope the West rises to that challenge. I think it's very important.
If you have any further thoughts in terms of how the private sector can effectively engage with government, or if you have any examples that you want to share in terms of a success or a failure and why.
Well, I think the private sector engages with health systems and governments all the time. I mean, it's not healthcare providers don't exist in a vacuum, and the private sector is supplying inputs to the public or non insurance-based providers all the time. But I mean, as I said before, I think we could probably do more in terms of the use of sort of public-private partnerships and using those to sort of harness private sector capacities, I think. Their success really depends on the extent to which interests within that partnership are aligned, and it's when you get misalignment between the interests of each side that I think you get problems. And if all the risk is being passed down the line down the supply chain to the private sector, or to the suppliers of the technologies and the innovations, then and there's no attempt to sort of share risk and reward, then that's when those kinds of relationships don't work. I think we've seen that clearly in the UK with the private finance initiative 20 years ago, where risk was passed onto private sector suppliers, and you got very little innovation emerging from that. So we have private sector involvement even in the NHS, a huge amount of private sector involvement, and it should be encouraged, but it needs to be managed as well, I think, and interests, as I say, need to be aligned in order for those relationships to work well.
So I think perhaps through government ministries of health, and as James has already said, this occurs already, via academia and government research funding. An example of that might be the EU, the European Union Horizon, and in Britain through the UK Research Initiative as examples. Although I noticed recently China's making huge steps in this direction for European collaboration in healthcare via an organisation they're setting up with significant funding in Shanghai. I think through involvement in cooperative working with organisations like the World Health Organization and organisations such as the British Standards Institute, which is sort of now moving into healthcare technology and trying to develop standards, the universal standards around the globe. I think examples sort of include the joint participation in eHealth programs between EHR software vendors, in governmental projects, for example, in NHS England, delivering such systems as Cerner, which has recently been acquired, I've noticed, by Oracle for $28.8 billion US. So hopefully leading to further development of the product and an opportunity for expanding in the global market. I think Oracle have clearly sort of decided that this is an area of potential huge benefit, as organisations like Amazon have as well. So I'm quite optimistic about the big players. I'm not quite sure where Europe's going to fit in all of this, as we tend not to have too many sort of high-tech companies, be it IBM, an IBM in Europe, or an Oracle, or a Microsoft, or an Amazon, or a Google, or a Facebook. I'm not sure where we are with the HR vendors, and I think it's an area that needs to be addressed in Europe. But there we go. So that's my thoughts. Sorry if I
Thank you.
Thank you.
What I would like to do is to give you two actual examples of things that I and my institute is actively involved in right now that do bring these stakeholders together. So these are two that I feel are really exciting success stories. The first one is the Innovative Medicines Initiative program, which has been running for many years. It's where the pharma industry identifies an issue that is too difficult for it to tackle alone, and where they instrument calls for proposals and public consortia bid, and then they all come together and tackle an issue. And an example project that I'd like to raise is called H2O. It's actually about health outcomes. It's a European project with this hybrid consortium working together to facilitate scaling up of patients collecting health outcomes and everybody using health outcomes much more potently at the level of near to patient for joint decision making with clinicians, at the level of national health systems, and at the level of big scale research. That is a problem that, scaling up the collection and use, trustworthy, data protected use of health outcomes, no stakeholder could deliver that at a European scale. None. Only together is there a sporting chance. No promises, it's an early project, got some years to run, but that's the only way it could happen. Second example is where some companies have come together to sponsor my institute plus a second not-for-profit institute also in Europe to work together to bring multi-stakeholders to a kind of round table to chew over what might be the best strategies for knotty problems. So this is about really bringing them together. Industry's paying, but they pay us as not-for-profits, then they let go. They don't control the agenda, we do. And an example is, what are the success factors that would enable the public to be more accepting and positive about the reuse of their data for research? What are the concerns the public have? And what are the factors that might make the public more comfortable with their data being used for research? Again, that's a complex topic. No stakeholder has the answer to that. But industry is investing in helping stakeholders to come together. They're at the table, but no priority to them. The sponsors are there at the table along with many others. But I think these are great examples of working together to solve difficult problems. To me, that's all that we've got left. The easy single stakeholder problems have all been solved. We only have multi-stakeholder problems left in the world. Let's work together on them. And I've seen these great examples.
I think my last remark would be that it's not the technology. It's not the technology, both in terms of the solution to many problems. Technology can make a difference, and obviously does, but there are many other organizational and funding and social innovations that need to be put in place as well to deal with global health challenges. And then secondly, it's not the technology in terms of adoption. Usually the technology works, it's all that messy stuff around organizations and cultures and silos and so on that mean that good innovations don't get adopted. So I'll leave it at that.
Yeah, I might sound naive what I'm about to say, so forgive me. But I think, as with climate change, it's very important in the healthcare domain that we work truly collaboratively, because I believe the benefit of that outweighs any other consideration, and it makes it a better world. So I hope that our politicians, as they claim they will with climate change, put aside some of the conflict areas and we can work collectively and bring significant benefit. The world really needs it.